2016. This is Susie Shannon, the first vice president for the commission. Unfortunately, Bill Rosendahl is ill and will not be able to be here tonight. The clerk will call the roll, please.
Commissioner Shannon is here. Commissioner Sharp is here. Commissioner Andres Taylor.
Here.
Commissioner Arriola. Commissioner Avila. Commissioner Braun is absent. Commissioner Esparza.
Here.
Commissioner Griffith. Commissioner Hisaric.
Here.
Commissioner Jaques.
Here.
Commissioner Jimenez will be absent. Commissioner Mandel. Commissioner Roca. Commissioner Vick.
Here.
8 members present and a quorum.
Thank you. Now if we can get a motion for the approval of the minutes, please.
I move to approve the minutes of our January meeting.
Second.
All in favor?
Aye.
All opposed? Abstentions? Thank you. Okay, now we will move on to public comment. I have 3 cards here. Adam Cohen from the AIDS Healthcare Foundation.
Good evening, everybody. My name is Adam Cohen. I'm a public health consultant for AIDS Healthcare Foundation. I just want to talk about 3 quick things. The first is the agenda. The second is the contract between LA County and the City of LA. And the third is the duties of the Health Commission. First, I feel like the agenda could be a little more robust. The Health Commission can better establish itself and its duties by just making a little more substantive agenda. Second, if the contract between LA County and the City of LA is rudimentary or perhaps non-existent, I think this would be a great opportunity for the Health Commission to formalize a solid relationship and perhaps even develop a new contract. The third, I just want to reiterate the 4 main duties of the Health Commission. I believe this is the 4th meeting of the Health Commission. The first is to attend LA County meetings. I know that will possibly be discussed later. Once per year, publish a health services plan that discusses the health needs of the City of LA with a strategic plan to achieve any goals to improve the health of the City of LA. Twice, prepare and present a report to the LA City Council to evaluate the City of LA's progress towards meeting its health goals. And once per year, review a representative sample of LA County Health Services contracts, which provides health services in the City of LA. And that's all I wanted to share. Thank you very much.
Thank you. Okay, next is Heather Edney, Homeless Healthcare LA. Oh, Mark Casanova from Homeless Healthcare Los Angeles.
Hello, I'm glad to be here. My name is Mark Casanova. I'm the Executive Director with Homeless Healthcare Los Angeles. And I just wanted to say a few things related probably more to public comment. I try to make the rounds and make sure that people are aware of some of the life-saving things that my organization does or that are available in the community. And one, I wanted to commend the city for the plans that are being made for this really terrible homeless problem we have. And as part of that, I've been working on the initiative meetings with both the city and the county, and tomorrow's a very big day for some of those services. But my organization has been around for about 30 years, and we've been providing healthcare, mental health care, addiction services, and housing, and a lot of harm reduction type services for chronically homeless and homeless folks in downtown. And I have a site in Skid Row, partially funded by the city, to provide prevention services at a syringe exchange, which has quite a few drug injectors that primarily use opiates. And so I'm here to talk a little bit about that, because opiate use, as Obama has said recently very loudly, that there's an overdose epidemic. And the City Council has supported the Public Safety Committee's Narcan initiative to promote this drug. Narcan's a drug that reverses an overdose. And the easiest way I can show you is there's actually a trainer kit that's available. It's so easy to use. This reverses an overdose and saves somebody's life.
This trainer contains no needle or drug. To inject, place black end against outer thigh, then press firmly and hold in place for 5 seconds.
This goes in an arm and or muscle.
5, 4, 3, injection complete.
That will save a life. That simple.
This trainer may be reused for training.
And I wanted to just talk about Narcan and let you know it's a very simple process, and I would hope we can
That would be
get a
time.
lot of these out.
Thank you. Heather Edney, Homeless Healthcare LA.
Hi, everybody. So basically, I'm alive today because of that drug. I have been in recovery for 12 years, but prior to that, I was an injection drug user and was a chronic overdoser. And at the time, Narcan was not like a legal, thing that we were allowed to have. But as drug users, we're very resourceful and wanted to save each other's lives. And so we would get that, and when someone would overdose, we would give it to each other, blah, blah, blah. So, sorry, no blah, blah, blahs here. Anyways, I'm alive today because of it. I am, honored to be here and honored to be working with Mark because, we in our addiction do not want to die. We're just, troubled, and we have, a drug problem. So my mom is really happy about Narcan, so is my family, and I don't know, I'm nervous. I didn't really plan what I was going to say, but hopefully the takeaway message, you've got it, so thank you.
Thank you. Eli Littman.
Hello, everybody. My name is Eli Littman. I'm here in a personal capacity, but I am also a commissioner for the City of Los Angeles with with the Board of Neighborhood Commissioners. And I just wanted to say it's wonderful to see that the city created this health commission. I'm excited to see the work that you all will be doing. First, I wanted to see who has participated in, voted in, or some other way been involved with the neighborhood council in their local neighborhood. 1, 2, 3, 4. All right, not bad. Well, just as a way to talk about the neighborhood councils, it's our grassroots network in the city. These are all volunteers throughout the city who are part of the city family, and they're doing things like health fairs. They're addressing homelessness in their community and have come up with some really great plans on addressing homelessness. They're doing community events all the time. So if you are thinking about a way to spread your message or the work that you're doing as part of the Health Commission throughout the city network, this is a great grassroots network. So look up Bonk, email the commissioner. There's a department associated with Department of Neighborhood Empowerment. And if you're looking for an opportunity to kind of spread a message, and we've had fire department, police department, many departments come through the neighborhood council system because it's a great way to spread that message amongst the activists in the city. So I just wanted to let you guys know about that and make sure you include it in future discussions. Thank you.
Thank you. Wayne Spindler. Wayne Spindler.
Yes, the Health Commission. How many people are here to speak? My God, must be at least 20 people behind me to speak. Yes, you can hear them all in the crowd. We're doing so much to promote this commission. But where's Bill Rosendahl? Where is he? 2 weeks, 2 months now, we've been wondering, where's Bill Rosendahl? Where did he go? He went somewhere. How come he's not listed as where he is? See, I know where he is, but I just want to know if you know where he is. But I think this is a good thing. We can have absentee presidents of commissions, like we could have an absentee speaker of this commission. And I mentioned again about that puppet. You still have not gotten rid of that puppet of Herb Wesson Jr. looking up there. And I still asked, why isn't the president or acting vice president of the commission allowed to sit at the commission chair? That's where the leader of this commission sits, at the chair. but why can't you sit there in the chair? Because you got that puppet up there. And I keep mentioning that puppet up there, and right now he's trying to speak to me. Stick on the subject, you cocksucker. I'm trying, Herb Wesson. I'm trying to speak. You son of a bitch. I'm trying to speak, Herb Wesson. Get off of that dais. Take that puppet down. I don't want that puppet looking at me at this meeting. You don't want that puppet looking at you. Remove the puppet and allow the chair to sit at the chair to chair the meeting here. Everybody else is in their right seats. Why does the president have to kneel before the mighty Herb Wesson puppet? Herb Wesson is not a commissioner in this commission. Get rid of that offensive, disgusting friggin' puppet.
Thank you. Okay, we'll move on now to... I don't have... Is this your one? Okay.
According to the Brown Act, it says, you technically don't need your full name other than address the fact that you filled out a card, which I did. And addressing that little puppet up there, you should put him down because he is an offensive little runt that can barely climb up a curb, that disabled fool. But the whole point here is, on topic is homelessness. You're talking about a crisis, the war that the city of Los Angeles brought upon its constituents, the homeless population. A war on African Americans, a war on those who cannot in a dignified way receive services rendered, benefits rendered. Anything that is rendered to a person who is homeless is shameful on every one of you. What fucking hell service is that? Give these people what they need, a home, not a shelter. On item 6 and item 7 of the agenda for tomorrow's meeting, under 15/1138/S1, Herb Wesson, that little bastard midget up there, continues to deface the city of Los Angeles. Look around you today. Walk out onto a sidewalk and street, and for $2.1 million, you tell me that's going to be enough to fight the crisis, the war on homelessness? The hell with you. The hell with all of you. The crisis was with a problem with people who had AIDS. No one wanted to address it. The federal government stepped in and supplied money for demand. Demand of better services for people who have been infected with AIDS. And now you continue with this war on the homeless, African Americans, and the other population, the non-discriminatory population of people like myself. Fuck you, Herb Wesson. That's right. You and Weezer, your little clown buddy up there that keep looking at us, you offensive little shit. Get off that podium and let the chair take order of this meeting.
Thank you. Now, we'll move on to item number 2, which is presentations on health-related cost programs and policies. Our first presentation is by Juan Lopez at the Los Angeles City Controller's Office.
Thank you, Commissioners, for inviting the Office of the City Controller. My name is Juan Lopez. I serve as Special Assistant to the City Controller. I direct and manage our open data program and all of our technology initiatives. And I also brought along Chris Benedetto, our communications deputy, to help me out with a quick demo of our site Control Panel LA. And please feel free to interrupt with any questions and let me know what you want to see. Obviously, the county deals with most of our health and social services issues, but there are some things that we were able to find on Control Panel relating to health. So just kind of as a primer, Control Panel LA was launched in October of 2013. Folks told us it would take 4 years, millions of dollars to make. We put it together in 6 weeks and under 100K. Here we have our payroll and our financial management systems. So we have every payroll item from the city as well as our vendor payments through our financial management system. So we have a wealth of financial data available here. And I kind of wanted to be brief and touch on some of the highlights. One of them is our special funds. The city has more than 900 special funds. And these are, the metaphor I like to compare this to is imagine if you went to the grocery store and you were going to buy milk, cereal, and tomatoes. But you'd have to use a separate checking account to buy the milk, a separate checking account for the cereal, and a separate one for tomatoes, and so on and so forth. Special funds work that same way. These special funds are for very specific uses, and they have very specific sources. So they could be grants, they could be certain line items from the budget. And here I actually filtered down to special funds relating to health. There was about 10 of them, I believe, and about $10 million or so. And you can see some of the larger ones here. And this is all publicly available 24 hours a day, 7 days a week on controlpanel.la. And if you actually scroll off to the right, we also included the name, the email, and a direct phone number to the person responsible for that fund. So if you had a question about one of these funds and you wanted to use them for a health project or a health initiative, you could call this person and see if these funds are available. And another quick highlight is payroll. So if you go back to the front page, click on payroll, we also have the average healthcare cost of every city employee. The reason why we include averages and not exact numbers is for HIPAA concerns. We don't want to put the exact number because then you can tell what kind of plan they're on. So here we have the average healthcare, average dental, and average life cost for every city employee, including employees of our proprietary departments. So this kind of gives you a sense of where we are in the city in terms of the finances of healthcare. And did you have a question? So keep going. Okay. And the third thing I kind of wanted to show is we have all this data, right? We have more than 110 data sets. This data has been viewed more than 6 million times. So we have 6 million page views since we launched in 2013. It's been incredibly popular. And the reason why it's become incredibly popular is we don't just launch data just to launch it, just to have it out there. We try to do something with it. We try to put it to action. And we actually released a data set on procurement, so what goods the city purchases. And what we did is we designed these little data cards, little 5x4 cards that we were able to hand out to community members on different things the city buys. So the city buys $8,549 worth of soccer balls, or 6,492 ballots. And if you scroll down, you can see how much we buy fire hoses and how much we pay for frozen rats. And frozen rats is interesting. It's a lot of folks' favorite. That's for our zoo. Reptiles, obviously, frozen rats. So we did this not just for fun, but we did this to kind of drive a narrative and try to raise awareness about procurement. If there is a vendor who can sell us motorcycle boots or can lease golf carts or sell us soccer balls at a lower price, we want to take advantage of that. So we have the underlying data there with how much we pay in taxes, where it's located, who provided it for us, and it's really driving reform and raising awareness. So you can kind of see how something like this could be applied to healthcare or social services. And I also took the liberty, because the controller's office obviously oversees the entire city, and we're not limited to just the financial data, but we also kind of look at all data. So whether it's rest of the city or county or the state or the federal government, there are some sources that I'm not sure if you're all aware of. The county launched an open data portal about 7-8 months ago, and they have a health section as well. I took a look at some of their data. It's very demographic, but it's interesting. There's about 18 data sets. And then the federal government also released an open data site called healthdata.gov, and that pulls data from Medicare. And this is actually very, very robust data. And I was kind of poking around, and I found some interesting data visualizations around Medicare cost. So here you have a map of hospitals throughout the United States. And if you hover over one of the hospitals, you can actually see average payments and average annual discharges. And this kind of gives you a sense of Medicare holistically, right? As a nation, how are we facing this issue? And I hope that my brief presentation kind of lets you know how to harness open data. It's good to be transparent, but you've got to do something with it. You've got to put it to action. And that's what we've been doing since day one. Did you have a question?
We're ready? Okay. Is there in the list of vendors from whom the city actually purchases, do we purchase any services from the county that are health related?
So I did just a simple search on that. We have something called the checkbook. It's called the Checkbook LA, and it has all our vendor payments. And I did a quick search. Currently, this is it right here. And if you typed in search, you could get kind of a mishmash of different vendors and departments, and some of them are admittedly related to health, but they're related to the internal healthcare costs of the city, so city personnel.
So but we don't per se buy a service from the county.
That could be very well possible. You can see here the expenditures are huge. So what I'm trying to get at is we're trying to simplify this and make it more user-friendly. And there's a new version of the checkbook coming out in a few months where you'll be able to answer that question a lot easier.
Okay, it's just that, we are looking at least part of this health commission's role is to see if the county is performing properly in relation to the health of the city and the residents of the city. And at least one way of checking the performance is to see if they fulfill contractual obligations. The trick is we don't know if there are contractual obligations. The only document that I've seen related to that was from 1964 when the city health department went out of existence and the county took over responsibility. And the only payment that appeared to me to be in that agreement was that if a county employee had to appear in court for the enforcement of some health rule of the city would pay for their court appearance time. Now, I don't know if you're collecting on that now, but that's the only money that I saw in the 1964 agreement. So it's just something that I've been asking repeatedly. And
that's interesting. So what I could do is I could get back to the commission. I could do a more thorough search. Time constraints, obviously. I didn't know about this until late last week.
It would be interesting to know if we, quote, pay the county for services.
Yeah, I could do a more thorough search and get back to you. Definitely.
We've actually been waiting for this. The commissioner here asked for this information a while back, so I would like to see us get this information sooner than later.
No, of course. Yeah.
Certainly before the next meeting would be wonderful.
And your next meeting is a month from now?
Uh-huh.
Yeah, no, yeah, definitely. Before then.
Okay.
Yeah. Any other questions?
Yes. Want to make sure no one else is waiting. Thanks, Juan. Thank you for taking time to come join us and go over this. I agree that it's been a useful platform. The control panel recently facilitated a change in contract terms with LAUSD and the City of LA regarding children's meal contracts because the transparency features revealed certain suppliers that were not in compliance with a policy that had been adopted several years ago. So it's an extremely helpful tool that's delivered real results. My question for you is about thinking how we can use this available information to bend down the cost curve on employee health care costs. And whether you all have uncovered whether other cities have undertaken initiatives that have genuinely used the availability of the information about the extraordinary cost and portion of city budget for current and retired employee health care to actually drive initiatives around workplace wellness that may reduce that cost curve, freeing up resources for other important programs and services.
So the controller, one of the major charter obligations of the controller is to be chief auditor of the city. And actually, the controller's office is working on an employee benefit, personnel benefit audit, and it should be released in the next few weeks or a few months. But that's the kind of deep, thorough analysis that we can do is in an audit. As far as using data to kind of bend, as you said, bend it down, what we've actually tried to do is partner up with USC and LA Trade Tech and other Santa Monica College, other local colleges, to try to get pilot projects to analyze this data. There's just so much of it out there, and we don't have the bandwidth to go through every single line item. And we've been working with USC on a sick time analysis and trying to tackle that. But it's just so large that you can't have a cohort of undergrad students take a stab at it because they don't understand the data. Second, a semester is too short of a time to conduct a thorough analysis. But we definitely are working towards those goals.
Great if that audit comes out perhaps in advance of the next commission hearing, along with Commissioner Esparza's request for information. Maybe we could get that forwarded around to everyone.
Definitely,
the
yeah.
audit summary, that you all put out, this sort of letter at the beginning of the audits that summarize. It'd be great for everyone to take a look at.
Yeah, we can definitely have our office follow up with that, yeah.
Stay on your listserv and so on. Thank you.
Great.
Any other questions?
Thank you so much for your presentation. It's great. Love the fact that since the mayor has taken this role on, you see a lot more transparency in a lot of matrices. It's really great to see that. Do you have a subset on subject areas? I'm really specifically looking on how much is expended on homelessness, like every aspect of it, versus just the housing, but also how it impacts the health department, how it impacts every aspect of that.
So that's a very interesting question, and it gets to kind of connecting dots between data sets, right? So you have a data set on, say, vendor payments to homeless shelter providers, and then you also have personnel benefits, and all these dots need to be connected. And currently, the way we've structured this data is everything's kind of in different buckets, right? So connecting the dots requires more resources. It requires some tools and really some analysis that we haven't quite gotten there yet. We've been so focused over the last 2 years of getting this data out. Now we're really focused on trying to create value from this data, and one of those is connecting the dots. But in terms of homelessness, actually, I don't know if Chris, can you pull up the special funds around homelessness? So the special funds is, again, a huge number of funds. There's a lot of money in these special funds. And they're relatively easier to categorize because you categorize it by eligible use. And if homelessness isn't the eligible use, then obviously it could be used for some homeless matter. And I actually created a filtered data set around homelessness and housing. And it's publicly available here. I'm not sure if Chris can pull it up, but it is available on Control Panel LA. I believe it was about 40 funds in that data set.
Okay. So you don't have one specifically for homelessness and health?
No. I had one for homelessness and housing.
Housing.
But I could put them together.
That'd be great. Thank you.
What are you doing to help let people know that this is available? It's wonderful, but I have to admit that I was ignorant of this until we had you on the agenda.
Unfortunately, that's very true for many Angelinos. So since we launched this in 2013, the controller has kind of gone on a roadshow for the last 2 years. So he goes out to neighborhood councils, business organizations, basically anybody who would have us. And the controller goes through exactly what I just did. He shows you what's on here, how to use it, and kind of what his plans are, what his vision is for open data. So we've been doing that for the last 2 years. We're also trying to look at ways, we also use social media, but we're also trying to look at ways of creating value. So if I can create value for a subset, right? So let's say for folks who are passionate about bicycles, if I can make something related to that, then you have this kind of a viral effect where if you could provide value to a certain group, then they can use it. And by using it, you kind of spread the word. So that's kind of where we're at now.
Okay, thank you.
But we'd very much appreciate it if everyone here can talk to their colleagues and partners about open data and Control Panel LA as well.
Great. Any other questions? Thank you so much for coming. This is very useful information.
Great. Thank you so much. And I just have one question. So who should I send the follow-up items? I believe there's a few items. Who should I?
You can send it, yeah, you can send it to me because I think they have my email address as
Fantastic.
well, to both of us.
Thank you again, and you guys are doing great work. Thank you so much.
Great, thank you. Okay, our next presentation is by Dr. Mark Eckstein, Medical Director for the LA City Fire Department.
Good afternoon. If we could adjust the slides. could just work with that if it's okay. Anyway, thanks for inviting me this afternoon. Put together a few slides talking about some of the projects we've been working on in the fire department as our mission really continues to change. A lot of what we do in the fire department now, it's not just EMS, but is actually in the public health realm. This pie chart really shows that overwhelming majority of our emergency responses now are actually medical in nature, and an increasing proportion of those EMS calls are actually really in the realm of public health, not even what most people would determine or interpret as being emergency medical care. So we're almost 90% EMS, about 1% structure fire, 9% other. So we've become an all hazards organization, but as our mission's changed, our prototypical response of sending fire engines and fire trucks and paramedic ambulances racing through the streets for the prototypical patients who have life-threatening emergencies such as heart attacks and gunshot wounds and car accidents still exist, but the number of those patients really constitutes a very small proportion of what we do, and it's the public health challenges that really is something the department now is confronting head on. So as I mentioned, low acuity complaints really taking up an increasing percentage of our calls. There's also frequent users, or what we call the Ems Super Users, where these are individuals who call 911 many, many times a year. And they obviously consume a tremendous number of resources. And really the insult to injury is when we respond emergency personnel to our so-called super users who typically have chronic medical conditions, substance abuse issues, mental health issues, and then these resources are tied up and not able to respond to the time-critical gunshot wounds and heart attacks and car accidents. That really becomes tragic. And our top frequent users or super users last year, the top 40 called 911 over 2,000 times last year. So huge problem, not unique to LA, but it's a growing problem. And then the small font there, the time-critical emergencies, which obviously is what the EMS system and the fire department is really set up to do and designed to do with, trying to achieve very short response times and provide life-saving care, constitutes a very small proportion of what we actually do. So we're taking recently a number of innovative approaches to try to confront the changing mission of the fire department and EMS. So some of these resources we've actually already put out in terms of pilot programs. Others we're in the process of creating. The first one is called the FRV, or the Fast Response Vehicle. And this is a picture of what we currently have. This was actually a converted new brush patrol rig, and it's really innovative fast response where we have two paramedics in a vehicle that carries both emergency medical equipment and water and hose for fire, so they can respond to EMS calls and fire type calls very, very quickly. It's two firefighter paramedics instead of 4 on an engine company. It's much faster and more mobile than an engine company. They provide on-scene triage, on-scene patient care. They don't have to transport patients to the hospital, and they become available to the next call very, very quickly. So we put 2 fast response vehicles out thus far in the last few months. One of them is located downtown. The other one is in the San Fernando Valley in the Sylmar-Pacoima area. The initial metrics are very, very compelling. These resources are very, very busy. They are out in the fields. They don't have the turnout time from the stations. They're canceling a high number of fire resources and not only able to provide patient care very, very quickly, but cancel resources and downgrade the call because they're providing triage on scene. So, for example, if the call was dispatched where they sent a fire company, a fire engine, and a paramedic ambulance, the FRV gets there first and may downgrade the call to an EMT ambulance and free up all those resources. So our preliminary metrics of these fast response vehicles, again, very compelling, and they're as busy as our busiest engine companies, canceling about 1.5 resources per response, and we hope to expand these as we move forward next year's budget as well. The other resource, which we're very, very excited that we just launched last month, is the Lafd Nurse Practitioner Response Unit. So this is a very novel, innovative program. We just started a one-year pilot on the Nurse Practitioner Response Unit. So this basically is a brand new concept, one of only a few that exists in the entire country, where we hired a EMS nurse practitioner, and he's partnered with an experienced firefighter paramedic They're an ambulance that's configured with a lot more equipment and akin to the nurse practitioner scope of practice. They're housed at Fire Station 64 in the Watts community and covered Battalion 13, which is South LA, which is a very, very busy, underserved community where we have challenges because we have both high and low acuity patients, but the call load, the demand clearly exceeds our supply. And there's also too few hospitals there as well. So we have a very underserved population. We also have a lot of vulnerable adults who suffer from chronic medical problems, and we also have a high number of the Ems Super Users. So the EMS, the Lafd Nurse Practitioner Response Unit went live January 4th of this year. Data is very preliminary, but so far it's, again, very compelling data. They are responding to low acuity calls with the concept of trying to do a very rapid, comprehensive treat and release and obviate the need for ambulance transport, freeing up our paramedics and firefighters. And they're also doing targeted responses with our Ems Super Users to try to get these individuals the help that they need in terms of assigning them a medical home to manage their chronic medical problems, substance abuse counseling, and mental health counseling. Again, we're very excited about this program. We hope to expand this as well. We're one of only 3 fire departments or EMS agencies in the entire country that have a program like this, and clearly the largest by far to have a program like this. This has gotten a lot of notoriety. This was funded by the Mayor's Innovation Fund on a 12-month pilot program. And again, the preliminary data is very, very compelling. We're helping a lot of patients. Rather than just providing episodic care, waiting for someone to call 911, they're actually proactively helping individuals with ongoing needs who just wind up calling 911 because they have nowhere else to go, or they perceive they have nowhere else to go. So this is, I think, setting a new paradigm for fire and EMS in the city of Los Angeles. The next phase of the nurse practitioner program I'm hoping to pursue, I just submitted another Innovation Fund proposal in the last few weeks, is to place nurse practitioners at our dispatch center. We have low acuity calls. The concept is certain low acuity calls would be funneled to a nurse practitioner seated at a console near our dispatchers at our communication center. Rather than dispatching ambulances and fire engines, emergency, the nurse practitioners would do a more comprehensive interrogation of the caller over the phone, and either to provide a clinic referral to these patients and not dispatch ambulances in the first place. They may dispatch a nurse practitioner response unit. They may dispatch an EMT ambulance, non-emergency, or dispatch a taxi cab to take the patient to a clinic or an emergency department. It's trying to marry up the patient's needs with the resources we have, again, rather than just sending ambulances and fire engines. So this is something we're very excited about with our next phase of our nurse practitioner response model. Some other projects we're working on, the sober unit. As we know, homelessness is becoming a huge issue, I would argue a crisis for the city of LA, as some of the speakers already mentioned. And a high proportion of the homeless individuals in the city suffer from mental health issues and substance abuse and chronic alcoholism. We're sending a tremendous number of fire or EMS resources every day to serve the homeless. Unfortunately, the system we have now doesn't serve these patients very well. We treat their immediate life threats, if there are any. More often than not, it's not an immediate problem. It's chronic medical issues, substance abuse issues, mental health issues, and so forth. We transport these homeless individuals to an emergency department. The emergency department fixes their immediate issue, and they get sent back out into the streets. So it's really a Band-Aid at best, and a very costly one, tying up a lot of money and resources. So we're partnering with Department of Health Services in LA County to open a sober unit, which will be a freestanding sobering center in a Skid Row area, which obviously where the highest need is in the city, which is our Fire Station 9's district. And I've requested funding also through the Innovation Fund to create a sober response unit from the fire department. And this would consist of a specially trained substance abuse social worker partnered with a paramedic, and in a transport vehicle, either a van or an ambulance, probably a van, they would transport public inebriates to the freestanding sobering center. The concept, these individuals would be able to sober up in a safe environment. The sobering center would be managed by a mid-level provider like a nurse practitioner and a case manager. Once the individual sobers up, they would try to be transitioned into inpatient detox and transitional housing. In addition, the sobering unit would try to target our serial or chronic inebriates on whom we're responding and transporting many, many times a day and a week, and try to get them definitive care as well. So the concept, they would be proactive and transport these individuals before they fall down, hit their head, and tie up the resources of a paramedic ambulance in a trauma center. This is something we hope to launch in and around July of this year. Finally, the other program I wanted to mention is something that's also we've requested funding for in accordance with the Homeless Initiative, is something I've called the LAFD Mobile Mental Health Unit. The concept behind this is to have an LPS certified social worker who usually serves as part of a psychiatric evaluation team, partnered up with a nurse practitioner. And right now, again, we're sending paramedics and firefighters to people who have specifically mental health issues, behavioral emergencies, not medical issues. It's not a good fit. We're tying up valuable resources. These individuals are transported to emergency departments that don't have psychiatric facilities. The ERs do medical clearance, and these individuals often sit for days waiting to get transferred to psychiatric beds, of which there are few and far between. The concept with a mobile mental health unit, and we would partner with MEU from LAPD. We would send this unit in lieu of engine companies and paramedic ambulances, and these individuals, this team could place patients on a hold and take them to an LPS certified emergency department, an inpatient psychiatric facility, or a drop-off facility such as Exodus, so these individuals with behavioral emergencies get the help that they need rather than just go to a generic emergency department. So these are just some of the innovative programs we're working on in the fire department, some of which we already have out there, others are in the planning stages, but the idea is to really match the needs of our patients, the needs of the growing number of individuals in the city who are homeless, substance abuse, chronic medical issues, mental health issues, who call 911 for lack of options or lack of perceived options, to provide them the right care, get them the help that they need, and free up emergency resources for true time-critical emergencies.
Great. Move to questions now. Thank you so much for coming out, and this was very helpful and informative. If it's okay, I'm going to ask the first question. Just for Skid Row specifically in that area, what do you have an estimate of what the cost is in terms of sending out fire trucks and EMTs and that kind of thing?
So it's really an opportunity cost. So Skid Row neighborhood, which is our Fire Station 9's district, is the busiest. It's actually the smallest district in the city. It's 1 square mile, and it's the busiest in the city. Engine Company 9 is running close to 30 responses in 24 hours now, which obviously is not sustainable. We have 2 paramedic ambulances and an EMT ambulance there full-time and another EMT ambulance there part-time. Those 4 resources are amongst the busiest in the city. So we keep throwing more resources at that fire station. They're literally running their wheels off because the homeless population is exploding in that area. And sadly, we're not ultimately helping these individuals. We provide life-saving care, but most of these folks need ongoing care for their other issues. So the cost of an ambulance is about $1 million in terms of salaries. Engine companies even more. But they're not available to respond to the time-critical emergencies, and it's literally a revolving door where they're transporting homeless patients to County USC. County USC treats their immediate problem. They get sent back out to the streets, and there's no definitive care provided. And again, the call load in that district now went up 18% last year, so clearly unsustainable. We're trying to throw some of these new resources in that district next year with the sobering center to finally solve the problem rather than apply a Band-Aid.
And with the fire, just to follow up on that, is the fire department budget, would that go to part of the sober living center?
So let me clarify.
Sobering center?
Yeah, the sobering center is not a sober living, it's a sobering center. We're partnering with the Department of Health Services, which is under the county. So they're funding the sobering center, which would have probably 35 to 40 beds. They'll pay from the structure of the building. The staffing, which would be a mid-level provider, probably a nurse practitioner and a case manager. I've requested funding through the Innovation Fund. We've got unanimous approval from the commission thus far. It's about $250,000 for 12 months for a full-time social worker and paramedic and equipment. The idea they would be picking up these individuals off the street, the serial and public inebriates, transporting them to the freestanding sobering center, to then get them plugged into inpatient detox and transitional housing.
Great. John?
One of the things that, of course, is the whole issue of the behavioral health. Are there adequate beds to transport folks to for facilities for the mentally ill?
So,
I mean, it's proven to be a problem I'm aware of.
yeah, no, that's an excellent point. Clearly, there are not enough beds. There's a real paucity of inpatient psychiatric beds, but what compounds the issue right now is we probably dispatch about 500 resources per week for patients with mental health issues, behavioral emergencies. And there's no policy within the county or city that allows our paramedics to transport these individuals to anything other than the closest emergency department. The patients go to the local ER, they get medically cleared, they'll wait for a PET team to come evaluate them, which may take 24 hours. PET team may place these patients on a 72-hour hold, and the patient may wait 5 days to find an inpatient bed, particularly if they're uninsured or just have Medi-Cal.
And they'll be waiting in the emergency room at that point?
3 to 5 days routinely.
Tying up the, yeah.
And the downstream effect is because a number, sometimes up to 25% of the beds of, say, a 12 or 14 bed ER is tied up with psych patients waiting to be transferred. Our paramedics can't unload because the beds are tied up when they have heart attacks and strokes and so forth. So the domino effect is quite significant. So the idea is to have expertise to identify patients with mental health issues, medically clear them in the field, take them right to a psych facility, either a psych ER, Exodus, or an inpatient psych facility, and skip the local ER, would help everybody, help the patients and free up our emergency resources and unload the ERs who really can't help these patients.
Of the training for both the EMS, for the basic life support, and the paramedics, how much training in handling behavioral problems do they get?
Well, clearly not enough, but they still have to be, even if they had additional training, they have to have the certification to place someone on a hold. Either only a law enforcement officer, psychiatrist, or LPS designated social worker can do that. So that concept is to have the LPS social worker who could do the mental health evaluation, put patients on holds, and the NP who could do the medical clearance all simultaneously in the field, so to speak. Because even if we provided more training to our paramedics and firefighters, they still have to transport to a local ER.
And the police do enter into the picture, and sometimes that choice is they end up taking them to a police facility rather than to a mental health facility.
Right, which clearly is a double tragedy because these patients, I think, would arguably do not get adequate mental health care in a jail, and often the mental health problems get worse, and they get tied up in the whole criminal justice system. So clearly, it's not serving the patients or the community as a whole.
For your leadership and vision running the department. I have 3 separate questions. 2 of them are kind of related. One is, what is the cost to the city per paramedic evaluation and transport?
So there's charges and there's cost. The cost is really hard to estimate because it's opportunity cost. So we have paramedics and firefighter paramedics, EMTs on duty, about 1,000 on duty per day. So you could argue they're being paid whether they respond or not.
Correct.
The problem is we've added many more resources to deal with the increasing volume. But if a paramedic ambulance is called to a patient, for example, with a mental health or behavioral emergency, and now that ambulance can't respond to your home when you or your family member is having a medical emergency or a heart attack, it's potential lives being lost. So we have charges. It's about $1,750 for paramedic transport in the city.
$1,750?
$1,750 and about $850 for an EMT transport. But the actual cost would be hard. A lot more math and analysis would have to be done to estimate the cost. But clearly, I could tell you we're barely keeping up with the growing demand. So our call load has gone up. And last year, our EMS call load went up 14%. Historically, our call load for EMS goes up 2 to 3%. Fires go down from year to year because of fire prevention. So 14% last year was unheard of, most of which is basic life support, not advanced, meaning it's the low acuity patients. And probably the 2 main factors is the exploding homeless population, and as more patients get some type of insurance under the Affordable Care Act, they're actually falling into the 911 and EMS system because there is a lack of primary care available.
Right. So I realize it's difficult to do a real analysis, but the 1750 or the 850 you had to develop that number somehow. So there's two separate factors. One is the real cost to your department or to the city of Los Angeles, and the second is what's recovered from billing either Medicare, Medi-Cal, or a private insurer, and for the small number of people who have no insurance, if there's any revenue from that. What I'm trying to get at is one is what is it really costing the city? Because this could be a net positive, it could be a net negative if you're really collecting half of some of these fees, or you'd be hemorrhaging money on it.
Excellent question. Let me try to address your question or answer it. The way the city charter is written is we have to be cost neutral. In other words, we try to attain full cost recovery, but we can't turn a profit. So to answer your question, the ALS and BLS ambulance transport fees are used with CMS guidelines, but they're predicated upon our staffing costs. Most of our costs are staffing. We collect about 50% of our charges. So we try to attain full cost recovery, we're about 50%. So clearly we're at least $50 million in the red, but the ambulance fees are based upon our staffing costs.
Right. And then the second question, going to your super users, the 40 or 50 or 100, whatever number you want to use it, obviously their demographics might be a little bit different than the average person who's calling 911. Do you have a sense on what kind of insurance or lack of insurance those individuals have?
Yeah, so we've done pretty extensive data analysis on our super users. Not surprisingly, majority were homeless, majority are male, and majority have chronic alcoholism. Interestingly enough, in South LA, where we started our first nurse practitioner response unit, the majority of our super users actually were not homeless. I'm of the belief it's very difficult to try to address the multiple needs of these individuals until they're housed. So the individuals we're focusing on in South LA, it's a vulnerable adult population. It's a large prevalence of chronic medical conditions, either undertreated or untreated or underdiagnosed, particularly diabetes, hypertension, and COPD. And there may be a combination of some substance abuse, mental health issues. And we're working with a various number of stakeholders, both the county health services, MLK facility, Partners in Care. So there's also some non-governmental agencies to do follow-up with social workers and so forth. Some of these surprisingly, a majority of these patients actually have some form of insurance, Medi-Medi, VA, Medi-Cal, HMOs. It's really connecting the dots, and that's where the NPRU does a comprehensive needs assessment on these individuals, and we're bringing in multiple stakeholders to try to get these individuals the help that they need, get them impaneled for a primary care physician. Mental health, substance abuse, we have a number of productive meetings with the leadership at MLK. The new MLK complex is predicated upon outpatient care. So we're only a month into this program, but we've had some very significant victories already. We're going to incorporate NPRU into our dispatch system. We've had a number of interested parties from some of the large accountable care organizations. And I think, again, we're just on individual success stories. We have individuals, some elderly patients who call 911 several times a week. But just doing a home evaluation, medication reconciliation, getting them impaneled is huge. Our paramedics are going to these patients over and over, but they're not helping them. So data is very compelling so far. From a financial perspective, cost versus charges, again, the numbers are based upon cost neutrality, full cost recovery, but we achieve about 50% of that.
Right. If you can get them a medical home, you're going to actually decrease a large number of your runs that potentially could be used elsewhere.
And that's the goal. And even the factor in the transportation piece, there was concern a lot of these individuals lack transport, and we're working with a number of avenues even to get them taxi vouchers to get to and from the clinics.
Okay. And my last question, going back to the nurse practitioner at the dispatch, which I think is a wonderful idea, have you guys looked into the possibility of utilizing nurse practitioners that are actually housed elsewhere? For example, Kaiser has a very good system of nurse practitioners who are on the phone 24/7. A lot of the ERs in the county and in the city have their own nurse practitioners where they actually subcontract them out to corporations or other groups. Have you guys looked into the capability of maybe using those to lower costs?
Excellent question. We've had a number of very productive meetings with Kaiser leadership. They're very interested in working with our program. Kaiser Foundation has actually donated some funds to help with the success of the NPRU. And we are exploring those opportunities where they might either provide some of their own nurse practitioners or funds for us to hire nurse practitioners and expand, not just cover Kaiser members, but other members within a specified community, probably around the Kaiser, like a Kaiser catchment area, like Hollywood. So we've also had productive meetings with leaderships from other large hospitals. So I think this is barely out of the infancy stage. I'm very optimistic that we will be able to have private-public partnerships to greatly expand the NPRU concept. I selected South LA for a number of reasons because of a very underserved community, a lot of vulnerable adults, a high number of super users, a paucity of hospitals. But clearly there are a number of other neighborhoods in the city that need the same type of services.
Right. The other group to look at is there are some large federally qualified health centers that have multiple centers actually, and they need to have 24/7 coverage for their clientele or their medical homed patients. It might be interesting to do a public-private partnership with them because they have some funds but not enough. It sounds like you have some funds and the expertise but not enough. And that potentially you could serve two services, one of which is to connect with them so that somebody who is not currently having a medical home all of a sudden has some nurse or some group that they could go to, and alternatively you can have some revenue so you can actually expand the program.
Yeah, all great points. And I think we're trying to achieve really a paradigm shift. And this is not to replace our paramedics and firefighters, but again, our whole system was designed on that 4 to 6 minute response time, time critical calls, and what we're dealing with now is the explosion of everything else.
Yeah, thank you.
Thank you.
I just had a quick follow-up question. You were talking about, particularly in South LA, some of your super users were insured. And I'm just wondering, are they underinsured? Or is it that they're not getting proper primary care? I mean, what are you finding? We're trying to identify some of the barriers that people experience just out there, particularly in underserved communities. So I'm just wondering what you're seeing, as the sort of first responder.
Combination of all the things you mentioned. A lot of individuals now under Covered California have a Medi-Cal HMO, Healthy OLA, those types of insurance plans. But there's a paucity of providers who are willing or able to see them. So I think that's one of the things that's really led to the explosion of nurse practitioners and physician assistants because there are not enough primary care physicians available. And the metrics, basically, if you take a Medi-Cal HMO patient into your primary care practice, you're probably going to lose money on that patient. The numbers just don't add up for Medi-Cal reimbursement. So it's a combination of sometimes these patients are they're not impaneled. They have insurance, but then nowhere to go. They can't afford the meds. It's really the whole litany of issues. A lot of it is getting someone, a caseworker, to sit down and get them impaneled and make sure they understand their medical issues, their medication reconciliation, all these types of things. What's happening now is for the combination of variables that you delineated, they call 911 when things go south because they're not taking their blood pressure pills or their insulin. Now they're in a crisis. They call 911. They go to an ER, end up in an ICU at an exorbitant cost to the system. So we're trying to really, the proverbial ounce of prevention, pound of cure philosophy is largely where we're trying to approach with some of these programs.
Great.
There was another issue. Speaking of super users, certain skilled nursing facilities rely on the fire department a great deal to respond to things where people fall out of bed or have other problems. And the city of Santa Monica, for example, has recently passed an ordinance to incentivize those skilled nursing facilities to make alternate arrangements. In other words, have a private BLS ambulance to do transfers and things along those lines, because I know in the Valley, for example, some nursing homes, they respond several times a week, and for things that, frankly, they don't need to go to, or at least, So I just wondered how much of an issue that is, and is it something that the city might take action to put some incentives on skilled nursing facilities to make other arrangements?
I think your points are well taken. I think once it's a financial incentive, to find an alternative means to help your patients. That, whether it's false alarms, I mean, it's an example, that's, money talks. So, clearly there are medical emergencies in skilled nursing facilities and nursing homes, but in terms of some of the chronic low-level complaints that you alluded to, I completely agree. Right now, there's no disincentive for these facilities to simply tell their staff, call 911 for just about anything and everything, and they do. And then the insult to injury, often their staff is told not to provide any medical care, including CPR, till we get there. So until the laws change or there's some financial penalties, those things won't change. But yeah, we have a tremendous number of responses to those types of facilities that would probably best be handled by alternative means.
Just want to thank you again for your presentation. I work in public health, so it was really good to see sort of the preventive approach, sort of trying to get to the root cause of the issue. One of the things I wanted to know from you is how will these efforts be evaluated, and when can we get access to this information? Because I'm very, very interested in sort of hearing some of the outcomes. I know costs will probably be something that will be measured, obviously, but just interested in other ways that these initiatives will be evaluated.
Thank you. So certainly so far, the Fast Response Vehicle and Nurse Practitioner Response Unit, again, those are operational. They were funded by the Major Innovation Fund, so producing periodic data reports. But more importantly, I plan to do at least probably a 6-month comprehensive evaluation of the Nurse Practitioner Response Unit, lessons learned, ideas for the future, probably at the Board of Fire Commissioners and the Public Safety Committee. And certainly be happy to address the larger body of City Council if requested. And we also plan to write up and publish our findings as well in a medical peer-reviewed journal, because this is, the issues that we discussed today are not unique to LA in any way. They're problems that every major city in America is dealing with right now, where their fire and EMS departments are overwhelmed with these types of problems and are looking for new and innovative approaches to better deal with them.
Any other questions?
Thank you so much for your presentation, and also thank you for your leadership, your innovative approach to how you're addressing these issues. It's really interesting to me, you're focusing on all these issues like homelessness and non-emergency responsive issues. I'm curious, what's the percentage that you address on actual fires, actual emergencies specifically, compared to everything else that you're dealing with now addressing the homelessness issues?
So, I think of the fire department, it's all hazards, almost like an insurance policy. If everyone has a fire extinguisher in their home, you probably never use it, but you want to have one there. A day like today, where there's red flag conditions with the Santa Anas, we pre-deploy 18 fire companies because, heaven forbid, there's a spark, half the city can burn down. In terms of the statistics, we respond to about 850 EMS incidents per day. We transport about 650 patients to hospitals per day. We go on about 12 to 14 structure fires a day. The rest are in between, wires down, automatic alarms, and so forth. As a percent, we're about 90% EMS, 1% structure fire, 9% other. Clearly, the risk to our members and cost is highest for structure fires in terms of safety and so forth. And to find that balance is the challenge. But in terms of acuity, majority of our calls are, well, let me rephrase it, in terms of true life and death, life-threatening calls, it's less than 5%. It's often difficult to identify those over the phone. We have tiered dispatch, but we always err on the side of the patient.
And is the response time impacted by addressing the other issues?
Well, clearly, it's a huge issue. So when our fire companies and ambulances are responding to all the low acuity calls, they're not available for the real-time critical calls. So if I have a fire engine, a paramedic ambulance on a super user, they didn't know up front, but it turns out someone who's called umpteen times, and then we have a child hit by a car, I may have an ambulance coming from downtown LA down to Watts, which is not uncommon. So it's that domino effect that we want our fire companies and paramedic ambulances available for the legitimate life-threatening EMS and fire calls, have these new specialized resources really able to mitigate everything else. Because right now what we're doing, again, is just not sustainable. As, like you alluded to, prolonged response times, bad outcomes, ambulances tied up at hospitals with patients who have behavioral issues. So it's really a domino effect. And the idea is send paramedics to life-threatening calls, send fire companies to fire calls, and send these specialized resources to everything else. And we'll never get 100% balance like that, but it's not just to free up these companies, but we want to get these individuals the help that they need, not just take them to the ER and they get a Band-Aid and go back out to the streets.
Right. It's really great that you're trying to find solutions to augment, but kind of talking about the issue of it's an insurance policy, and that's what the LA taxpayer dollars are going for, is to address these emergency issues as well as these other systemic issues as well. So it's really interesting to me as far as these two ideas that you propose as far as pilots, as far as funding, understanding that, there's great funding through the Innovation Fund as you've tapped into. But going back to my colleagues, the other commissioners' point about public-private partnerships, it seems like there's so many other entities, whether they are FQHCs, whether it is county, whether it is city, whether it is nonprofit organizations, whether it is churches, that are all addressing the issue of homelessness as far as coming around the rapid response issues to address the vulnerable population. What is being done to bring them all so that it becomes a sustainable project, or becomes a community holistic project, so that's not just a pilot once a year hoping to get refunded issue?
Your point's well taken. So we have reached out to a number of both government and non-governmental organizations, faith-based groups. We're trying to see what are options to get additional funding, because the sustainability is a big issue, let alone not just to maintain the programs, but to expand them. So we are exploring a number of options. I think the ultimate solution is a public-private partnership, because the hospitals now are all large ACOs for the most part. They realize that it behooves them financially to keep their patients out of the 911 system, which is episodic, unscheduled care. It's much better to have preventive, scheduled care. And we, I think, provide a great solution to help support that. So the discussions we've had with, for example, Kaiser and Cedars and CHLA have been very productive. I'm optimistic we're going to be able to come to an actual agreement with one of those entities this calendar year, hopefully this fiscal year, because they see this as a win-win situation for everybody, not the least of which are their patients. I think they wanted to see us get this first program off the ground, which we have. We're going to have some early data, and once we've demonstrated we can pull this off, I think they really will want to partner with us for the betterment of everybody.
Thank you for your leadership.
Thank you. Appreciate that.
What's your annual EMS budget?
Well, the fire department budget this year, I believe, is about $655 million, thereabout.
It's about 90% of that.
But, well, no, most of it's salaries, but it's hard to distinguish how much goes for fire suppression versus EMS. Almost all of our paramedics now are dual function. They're firefighters and paramedics, so it's really hard to answer your question specifically what goes for EMS versus fire. Overwhelming majority of our budget is based on salaries. The heavy apparatus is paid through bond funding through MICLA. So like $1 million truck, that's your bond money. So it's very hard to separate out what percent is EMS versus fire in terms of the budget.
Okay, any other questions?
Just a comment. I hope we get your contact information, because I'm very connected to quite a few nonprofit agencies that would be very interested in what you're doing. I assume you're working with HASC and Hospital Association of Southern California.
Well, I've reached out to HASC. Yes, we haven't asked for funding, but we're trying to be methodical. I've also applied for funding through California Endowment, through some federal grants. But clearly, any connections you have to kind of open the door to getting additional funding, I think would be very, very helpful, and I think would be, in terms of good stewards of the taxpayers' funding, public-private partnerships, particularly through nonprofits, clearly would help us not just sustain but augment these programs.
Great. I hope we get the contact.
I'll share Dr. Eckstein's contact information.
Thank you.
Just to echo on that issue, it's a really great time to actually see leaders come together at the local and state and federal level. Right now, you're looking at the state of California putting about $2 billion up in the next 5 years. You're looking at, through the 115 waiver, about another $15 million or so. So it's really interesting how all the community partners are coming together with the funding. You also have LA City, as the CAO's report on addressing the issue of homelessness. Is there an earmark specifically in his plan that you're aware of addressing this issue to fund this project?
So my understanding through the proposed budget for the homeless initiative from the City of LA, the fire department has requested significant amount of funding for that. Number are in the programs I mentioned, so specifically expanding all these programs, the FRBs, the NPRUs, sober units, and mental health units. were all requested as part of the budget package for that homeless initiative. So we're working with the CAO's office, and hopefully we'll be successful getting that additional funding for those resources to help this growing population.
Great. Any other questions? Okay, thank you so much.
Thank you very much.
Thank you very much.
Okay, our next presentation is by Nancy Halpern Ibrahim from Esperanza Community Housing.
Thank you. Good evening. I regret that I did not have more time to prepare a more interesting visual. I'm afraid I am it. Commissioner Sharp is passing around some materials which may answer some questions that may emerge. I want to thank you for inviting me to speak with you today. My name is Nancy Halpern Ibrahim, and I'm the Executive Director of Esperanza Community Housing Corporation, which is a 27-year-old community development nonprofit based in South Central Los Angeles. My organization's mission focuses on comprehensive, responsible, and sustainable community development and land use. We meet our mission through the development of quality, affordable housing for families, economic development and employment opportunities, promotion of health education, health services, and primary prevention interventions, arts and culture, and environmental justice. Perhaps our two most recognizable contributions to community health are our 20-year-old community health promoters, or Promotores de Salud program, which has graduated 462 Promotores de Salud over the last 20 years, and the Mercado La Paloma, which is where it all comes together for us in South LA, as our economic development venue and cultural hub. Throughout all of our program areas, we serve approximately 200,000 unduplicated individuals a year. And you would think that we already have a lot on our plate, and I think that Commissioner Vick, who is one of our board of directors, would be able to attest to that as well. But as a responsive community-based organization, we always have to be available to conditions that change on the ground. And in 2009, in the area known as North University Park, where Esperanza has 5 buildings of multifamily housing, our community was suddenly overwhelmed by previously unrecognized peril. This is an area in a census tract that is mostly residential with 9 educational institutions. Noxious smells began to radically change the quality of life and health. In the beginning, neighbors began to complain about terrible odors that would interrupt sleep, interrupt classes, and interrupt other daily activities. And some of those smells are profound petroleum smells, and also the rotten egg smell that we have associated with some oil-producing sites. And what is sometimes even worse is terribly cloying masking agents, which are sickeningly sweet chemicals that are added to the petroleum chemicals to try to mask the primary chemical pollution. Shortly after these smells started infiltrating the neighborhood, tenants of Esperanza and neighbors began complaining of health symptoms. Upper respiratory illnesses, asthma, including adult onset asthma, nausea, dizziness, blurred vision, crippling headaches, and spontaneous nosebleeds. Spontaneous nosebleeds among infants, children, and adults as well. Gradually, we began to realize that the source of these ills was a 2-acre site discreetly tucked behind a well-landscaped gate and nested between Mount St. Mary's College and the Lanternman High School for developmentally disabled adults, and directly in front of multi-family residential properties, some of which are our properties. And the site was an oil and gas excavation site owned by Alanco Energy that had recently ratcheted extraction activities by approximately 400% in an arrogant disregard for public health and safety. Our initial response was to file odor complaints with the South Coast AQMD, receiving a range of responses from totally inadequate to downright disrespectful. We filed public information requests demanding to know what chemicals we were being exposed to. We have learned since that we've been exposed to toxins like hydrogen sulfide, methane, benzene, carcinogens, and endocrine disruptors, but none of that chemical information has come either from the energy company or from the AQMD. We organized telephone trees, kept logs of our phone calls, and we used popular education techniques to engage our broader community. We conducted door-to-door health data collection campaigns, asking local residents about health symptoms and perceptions of air quality. We called on the Public Health Department to investigate the site. Both Angelo Bellomo and Cyrus Rangan, two senior members of the staff, both had adverse reactions when they came to visit the site. By 2012, we began to take our struggle to the street in a campaign we called People Not Pozos. Pozos in this particular case being the Spanish word for a hole or a well in the ground. And began a series of public protests and media events, including a banner drop from one of our buildings that is in front of Alanco within 50 feet of the drilling site. Senator Barbara Boxer read a Los Angeles Times press piece on our banner drop and approached us almost immediately thereafter to do a follow-up media event at the site where she would call on the U.S. EPA to conduct investigations and for Alanco to close its operations. The U.S. EPA investigators were also sickened at the site, so the credibility of what community members were complaining of was replicated in just about every expert who visited. In November of 2013, in response to a growing list of publicized regulatory findings and violations, Alanco voluntarily shut down its operations. What we've learned during the course of our struggle at Alanco was that there was a host of regulatory agencies, city, state, air quality districts, federal, none of which were doing the job of protecting the community's health and safety, and none of which communicate with each other on a regular basis. Almost every agency on examination had a list of violations against Alanco, but none rising to the level of strict enforcement or fines beyond the cost of doing business. And while our plight inspired the city attorney to file suit against Alanco on behalf of the residents of Los Angeles, the city has made no policy changes to discourage the repeated issuance of permits to drill new and reactivate old wells. So as we began to publicize our struggle, we learned that there were more than 1,000 active oil and natural gas extraction sites in the city of Los Angeles. More than 750 of them, or 70%, are located within 1,500 feet from residential and other sensitive land uses. In Los Angeles, which is the home of the nation's largest urban oil field, 1 in 3 residents lives within a mile of an active oil well. Drilling near homes, schools, and hospitals threatens our families with risks of serious illnesses and catastrophic accidents. It is also making our precious housing almost inhabitable by destroying the air quality in the surround. So in LA, there are 130 schools, 184 daycare facilities, 213 elderly homes, and nearly 628,000 residents within a half a mile of an active oil well. The exposure to hazards and risks are disproportionately concentrated in communities of color that already suffer from cumulative health, environmental, and economic burdens. 74% of the residents who live within 1,500 feet of drilling sites are people of color. And at none of these sites is there a community evacuation plan. In fact, in South LA, our sites are some of the oldest neighborhoods on the West Coast, with streets that were built for carriage traffic, not for 16-wheel tankers hauling toxic substances in and out of neighborhoods, or emergency vehicles, even those cleverly modified ones that our last speaker just spoke of. 2 years ago, our People Not Pozos campaign began to join forces with other environmental justice communities in South Los Angeles, and have recently branded ourselves as Stand LA, standing together against neighborhood drilling. We are an environmental justice coalition of community groups seeking to end neighborhood drilling to protect the health and safety of Angelenos on the front lines of urban oil extraction. We believe that city officials are responsible for protecting the health and safety of their constituents. We believe that this commission is a great trend that we're beginning to work with. So I'm very grateful to have the opportunity to address you. The risks associated with neighborhood drilling are now well documented and unjustifiable. Our communities, not oil and gas corporations, should have the power to shape a safe and healthy future for our families and for Los Angeles. So the laws regulating oil and gas extraction in LA have failed to protect our communities. We cannot afford to wait. We are calling on the city of Los Angeles to enact a 1,500-foot human health and safety buffer around all oil and gas extraction activities. As part of the Health Commission's strategic plan to improve health outcomes for Los Angeles residents, I strongly recommend that this commission urge city and county policy members to support Stand LA's call for a 1,500-foot human health and safety buffer around all active wells. Our proposed ordinance is based on sound legal precedent and is well within the jurisdiction of the LA City Council to implement. I would like to say just near closing that in the 8 or so minutes in which I've been talking, I have not mentioned Porter Ranch once. The story that I've just told you began for us in South LA actively in 2009. While Stand LA, People Not Pozos, Esperanza Community Housing, we all actively stand in solidarity with the families of Porter Ranch, the irony and the disparate treatment is not lost on any of us. So never at any time has anyone in South LA been offered the opportunity to relocate from their home or their school to find accommodations from such a pollution. This is a ghastly problem, and our city really needs to come to terms with changing policies as they relate to oil and gas extraction within city limits. Otherwise, we're going to be dealing with Eckstein and Porter Ranch and other catastrophic abuses of our environment. Not to mention the great democratizer, which is global climate change. Climate change begins at home, and I'm very grateful for your attention and in advance for any questions that I hope I'll be able to answer. Thank you.
Great. Thank you. Thank you. Any questions?
I just want to say wow and thanks again, Nancy, for all the work that you do and your, is it 482 Pomodoro graduates?
Nearly. Thank you.
I've had the pleasure of working with, not 400 of them, but several of them. So excellent work. That you
Thank
do.
you.
thank you for rearranging plans to be here with us tonight. I think everyone has benefited immensely from the succinct way you've summarized the challenge and an obvious and important step that we should certainly take our resources to help endorse. You identified earlier the regulatory stew in which this has been lost, and I think that seems to have been a thread in the Eckstein story, which affected a small number of Boyle Heights residents as well as those in other surrounding municipalities near the Vernon plant. Your best understanding is that current city departments do not have a staff person hired who's responsible for monitoring the cumulative regulatory violations of residential health.
Absolutely. Yeah, there's no ombudsman, there is no clearinghouse. And I think, interestingly, last week, Councilman Wesson introduced the idea of the city hiring a full-time petroleum administrator, which is a sort of archaic term of an absent position, but that's been on the books for decades. And from my perspective, adding that position now represents something that is too little, too late. But more to the point, if the petroleum administrator is actually a representative of the petroleum industry, things will get very, very much worse. And I think considering the trends that this very commission represents and the health element represent in the city of Los Angeles beginning to engage in issues related to public health, I think what this city needs in terms of administration is perhaps a public health and safety administrator, someone who is grounded in health. I think that would be a much more cost-effective use of city funds to have a hire who is actually grounded in health and well-versed in the chemical background as well.
Thank you. I certainly agree with the suggestion that there be a 1,500-foot buffer and agree with your suggestion on how to construct that position in a way to best advantage residents' health first and foremost. So thank you for those suggestions.
Thank you.
Thank you. So I have just a few questions.
Yes.
One is, during your testimony, you talked about finding out that some of the chemicals that you were exposed to are hydrogen sulfide and endocrine disruptors. And then you said that none of the information came from the South Coast AQMD. Where did you get the information?
We've gotten that information from doing deep dives into what constitutes emissions from petroleum in general. You know, these are chemicals that are always present. We also know that hydrogen sulfide is a substance around which there are warnings within the Allen Co. site, but not on the outside. So that there are certain protections on the inside that don't extend to the outside of the site. And we have also looked at certain physical symptoms that reflect a consistency with those kinds of toxicants. One of the things that we're very concerned about, if you're living in the midst of a polluter 24/7, the OSHA and the AQMD standards for what constitutes a health or risk standard don't apply. And in the case of hydrogen sulfide, one of the greatest risks is that you stop smelling the materials that you're being exposed to, which makes it all the more dangerous because you don't, the one sense that you are expected to use to get out of harm's way is no longer working for you. And so even though Allen Co. has been shut down since November 13th of 2013, we've had 2 successive Thanksgivings when folks in the neighborhood have been very grateful to be able to open up their windows and to stay as residents in their own homes. The community remains very, very much on edge that the site is going to reopen. And a lot of the symptoms, the deeper damage, are clearly in evidence. So while we have seen almost all of the acute symptoms reduced by at least half since the site shut down, many folks have not yet gotten their sense of smell back. adult asthma is a problem that didn't exist for many people who had lived in that neighborhood for many, many years. And that's not something that's going away overnight.
Great. Thank you so much. Any other questions?
Thank you so much for your presentation. It's actually very, very heartwarming to hear your report and understanding that the fight still goes on for a lot of the underserved. I've been very blessed to work with great legislators on the issue of environmental justice, whether it was Suva Elementary, the chromium in the water, down to the children having asthma, cancer. You start seeing it across the board, especially also addressing the issue of the Alameda corridor and that's direct impacts. I've realized that it comes down to dollars and cents when you come to working with legislators and talking about impacts. So I'm trying to figure out, how do you quantify all the dollars that this particular underserved community is using to go to the emergency rooms to address the issues of asthma, to address the issues and all the negative health externalities that happen? How do you quantify all of that so that we can show it's definitely an epidemic that needs to be addressed?
I think that that's going to be a much longer-term research project. I was actually hoping that the speakers, the three of us, would be sticking around for each other and seeing where there might be some overlap. I think that following the money is an extremely important part of this story, and the cost effectiveness of actually putting prevention into action now. For me, the first act of prevention is if you are doing something that is making the community sick, stop it now. If it's in the ground, keep it in the ground. We have had conversations with lawyers, with the city attorney's office. They have been extremely respectful of our community, and yet they have a particular process that they follow. Our community has often been asked, what would a reasonable settlement be with this oil company? And our community members have said, just speaking truth to power in whatever configuration they get to do so, that there is no price that can be put on the lives of their children or their elders. And if they were to move, would that there were housing in other areas that they could move to, other families would move in and take their place. And there's no way that the price of the damage done to families can be assessed that way. The other piece about long-term damage, we have focused our work, because the burden of proof is always on the community that's being poisoned. We've focused our door-to-door outreach on the acute replicable symptoms, but we also know that there's a preponderance of cancers, that these are becoming cancer clusters. There is a suspicion that there are hormonal disruptions and leukemia among boys in particular in the area, mostly around 14 and 15 years old. And I know that that's a difficult assertion to back up with science, and we're being very, very careful not to run into being accused of junk science. So we know that there are things that need to be assessed by people who are don't have the skills or have other skills that we do not have. But I think that it's already been far too expensive. And even the mental health, the stress that families are going through now of, do they leave quality, affordable housing, which is at such a premium in this city, because they think that this site is going to open again and expose them to harm yet again. I think it's already been far too expensive.
To address the issue of mentioning AQMD, is there an environmental justice ombudsman or a czar in the city? What is the process?
Well, that's part of the problem. I think the community is the process. The community, it's been up to the community to connect the dots and to make certain discoveries. So while the AQMD has, for all appearances, is sort of put up as the first line of regulatory approach, we actually wasted years doing things pretty much the right way by following that course, and then we started to look into other things. And we've discovered laundry lists that the Department of Gas and Geothermal Dogger has on Alanco a laundry list of perhaps 15 major violations. The fire department has a list of violations against them. So what we discovered at Alanco, which is within feet, it's within spitting distance of housing where people live and schools where kids go to school, 3 out of 4 fire eyes over a period of 2 years were not working at the site. So things can go very badly in a volatile way very quickly. And as I said, there's no emergency evacuation set up. So we've discovered there are water resource violations. There are DWP violations, and no one has actually been tracking that. To her credit, Sharon Lowe from Gil Cedillo's office, this is actually in Gil Cedillo's, the southern part of City Council District 1. And so Sharon has done a job of trying to convene all of the parties, from Barbara Boxer's office to the fire department to AQMD to have regular check-ins with each other. But it's been the result of a very long and gruesome struggle on the part of our community.
Thank you for your leadership.
In your recitation of your presentation, you did mention the Department of Public Health of the county. I wasn't quite sure what role they played and how whatever they do would be in relation to what you propose as a city public health advocate.
Well, I think the city is responsible for, planning is responsible
Zoning
for
and
actually
that sort of-
making
yeah.
this stop, not
I see.
permitting it in the future, and calling quits on a practice that is doing our families harm. So I learned just recently in the course of this investigation that in 1967, I moved out here in the early 70s, and I knew that dairy farms, until fairly recent living memory, had been included in the city limits. So there was Ador Farms, Altadena Dairy, there was Santee Dairy. All of these places had been operational until quite recently, and somehow the city, in its wisdom, determined that dairy farms were no longer compatible with a densely growing urban environment. The Public Health Department played a very, very interesting role, one that I have not seen them repeat since. But since both of the investigators became affected on site, they made pronunciations of, they pronounced the site a public health nuisance. They did so at an AQMD town hall, and they made they made remarks publicly that could not thereafter be retracted. It really showed public health actually putting its mouth where their expertise was, and in so doing, taking some of that burden of proof away from our community members, because we were still documenting everything up to that point. But being pronounced a public health nuisance site, I think was something that gave our community a lift.
Okay, I just was trying to, I see your point about the potential city employee would be kind of to monitor development and activities from a public health perspective as they go forward.
Well, the city itself has a mission to steward the community's health and well-being.
Planning.
Exactly. So planning remains an issue, even if on one side the city attorney's office is involved in litigation.
Right.
The zoning administration is still handing out permits. There's a contradiction there that I think all of us as taxpayers are going to be paying for down the road.
Any other questions? I have one quick question. The 1,500-foot health and human safety buffer, is there a model for that in other city, county, even
There's
other countries?
Dallas, Texas, of all places, the big bad daddy of them all, in their wisdom, have decided that there needs to be a buffer between excavation and human habitation. The 1,500 foot as an air quality zone of interest is actually established in other conversations by the South Coast AQMD. And so we wanted not to pull pie in the sky, but actually use air quality measures that were known and familiar in whatever lexicon we're using. But we're hoping that with these 1,500 foot buffers in a city that's as dense as Los Angeles, that in time we will find that there's no room for these kinds of practices in our city. And it's time for us to embrace other historic uses for the city of Los Angeles.
Great. Any other questions?
At what point would the city zoning administration not be able to give another permit?
I think that has to go through council. That has to be made as a recommendation from council. It would go to the city attorney's office. Policy would be made and instructed to the various departments of the city. It has to be done within legal channels within city law.
Okay, thank you. Thank you so much for coming.
Thank you.
Okay, now we'll move on to public comment for item 2. Mr. Herman?
It really would have been nice had the fire department rep, Mr. Mark Eckstein, would have stayed to listen to the lady's fine presentation. As you heard, their salaries are based on $665 million. And how much of that really is a sacrifice of political interest for anyone? Zero. Why? Because we have a crisis called the war on homeless in Los Angeles. It's become the earmark of Herb Wesson, the crying deaf ears of Herb Wesson. Why do you sacrifice political speech to a formula of a crisis on homelessness? You engaged the war, Herb. You at the cost of the public. And now you're sacrificing it along with our mayor, Eric Garcetti, based on the Krikorian budget. And again, all because you can't seem to get the picture together. There's a plot and there's an end. And you started off with the end, the demise of human lives that don't fucking matter on our streets, Herb Wesson, you little puppet. I'm looking right at you, Herb, and you sit there like a deadbeat little log, the same size you are in real life. And I'm telling you, do more for homeless people. Stop the rhetoric of all this fucking talk and do something for homeless people. How much clearer can I be about it? African Americans are dying by the day in the city of Los Angeles. Hispanics and Asians, on the other half, are dying on the streets due to homelessness. But yet, the main people who are dying are our veterans.
Thank you. Wayne Spindler?
If you have a problem with me, just direct it to me. You want to play dozens like a child, then go right ahead. But if you have a problem with me, be a man and address it to me. Don't act like the 11-year-old boy that you are, all right? So, with that said, can I have the next speaker?
So there you go. Herb Wesson Jr., the threatening terrorist. That's what he is, and that's what runs this city. That's the kind of crap. That was at Friday's meeting in Van Nuys. So, you heard the truth. $655 million for what? Salaries, pensions, health care. For what? For a bunch of people sitting on their fat ass doing nothing. So what they have to do is create a profit center. So when your dad falls down or your mother has a bad hip and you call 911, these fucking pricks are going to charge you $1,750 to go from a fire station to your house. $1,750. And I know, because I got the bill from these pricks. And then you give it to your insurance carrier, and they find every way in the world to not pay it. Then they send it to a collection agency and try to run your credit down. And they charge interest and penalties. Why should it cost anything? It shouldn't cost $1,750. Just get rid of all of the fraud on the $655 million in pay-fair pensions. Then you wouldn't have to fucking charge $1,750 every time you call 911. Fuck that charge. That charge is absolute stealing for the pension fund that meets at the LA Times building every 2 weeks. Those pricks. No to that cost.
Okay, that concludes public comment for item 2. We will now move on to item 3, which is a verbal report back from any commissioners about attendance at county health meetings since January 11th, 2016, and continued discussion on proposed strategy for attending future meetings, preparing reports, and strategic plan. So do we have any commissioner report backs?
I can tell you that I attended the meeting of the Emergency Medical Services Commission, but there was not specific items directed to the City of Los Angeles. From time to time there are, for example, the programs that Dr. Eckstein described, like the nurse practitioner program, and those, they do come to the county's Department of Emergency Medical Services for review. It's not, I mean, they don't operate them, but they do provide oversight for all those programs on behalf. Actually, they do it on behalf of the state, the medical services for the state. But I did attend the meeting.
Great. Any other report
I'd love to
backs?
ask Commissioner Hisrich a question about his meeting prior to hearing Commissioner Vick's report, which is that from Dr. Eckstein's comments, I have notes of a policy that he referenced that prescribes transporting all patients to emergency rooms.
Right.
And I would benefit from, during your next attendance at the next round of that, to surface whether there are other local jurisdictions that have adjusted that policy to provide greater flexibility.
They're working, there is a program going on with the state that's monitored by UCLA. One is with the Glendale Fire Department and one is with the Santa Monica Fire Department. The Santa Monica Fire Department allows for the taking of some patients to alternate destinations. It turns out they haven't done it a great deal, but alternate destinations other than emergency rooms. The program in Glendale is different. That actually involves paramedics following up. If a patient's had a heart condition, they follow up with them to see if they're on their medications and so on. That's
Great.
a slightly different but related issue.
So we can rely on you if we determine that it's worthy to further explore the applicability of this policy.
Right.
in Los Angeles.
You know, for example, the one that he describes, the sobering program, which I think is an eminently good idea, but that will require permission to take the patients to something other than an emergency room. The same is true should they develop an alternate program for those exhibiting primarily behavioral health problems. There is, as he said, and I'm well aware, a considerable shortage of facilities for the mentally ill. I think Big County has something like 26 beds, and it fills up quickly. So finding alternate sites for those folks is a challenge, but one that I think, you know, as a commission we can take a look at because it certainly relates to the health of the folks in the city.
Okay.
So I attended the 24th Annual Empowerment Congress, which is led by 2nd District Supervisor Mark Ridley Thomas. I had mentioned it at the previous meeting. There was about 1,600 people in attendance that day. The topic of discussion was homelessness, and there were about 9 different workshops centered around that issue. The event was well attended by other county representatives, so almost all the departments were there as well in attendance, which I think was very valuable for them to hear some of the issues that were important around homelessness. There was also a resource fair afterwards so that residents that had attended could also access some of the services and information that was available from some of the county departments. In addition to that, I also attend the subcommittee for the Empowerment Conference, the health subcommittee meetings as well. So there was one last month and there's one this Thursday.
Great. Any other report backs?
If no one else has, I'll report back.
No, I just want to say that I only received the schedule of meetings today.
Yeah.
So I will make it a point of attending the Public Health Commission since I signed up for it.
Great.
Which is this Thursday, so I will make every effort to be there.
So related to that, on January 28th, I attended a meeting with Dr. Jeff Gunzenhauser and Dr. Cindy Harding, the Chief Health Officer and Director of the Department of Public Health, to learn about their strategies and to provide input on some of the steps they're looking to take to best serve underserved populations with their new strategic plan, which Commissioner Andres Taylor presented on in a previous meeting, I believe in December. And I took away 4 pieces of information that I'll quickly transmit to all of you, and then happy to talk offline if it's helpful to talk further, particularly if you're going to engage with their commission later this week. The Department of Public Health, to implement its plan, is very interested in working with each of the 87 cities in the county to actually adopt and implement a number of policies that have been either developed, enacted in some cases at the Board of Supervisors for the unincorporated areas, but in many cases not acted on in all the cities or any of the cities in some cases. And certainly where acted on, implementation seems to be a barrier. They're working to try and brand some of the messaging challenges. There's great confusion as to what is public health, both in the context of Porter Ranch as well as restaurant letter grades. There's a commitment but no resources to do better data analysis to basically support the platform that we heard about from Juan Lopez from the City Controller's Office, which the mayor has a version of as well, that includes a variety of health data sets, all of which are years out of date. And so there's an interest and I think a need that I'll try and raise later for the city and county to accelerate the information that's available about what's happening with health trends, what's happening with the health status, what are the costs. All of that is many years behind. And then this last and I think singly most valuable piece, which relates to Commissioner Jaquez's question at the very end for our guest, Ms. Halpern, to try and quantify the return on investment for prevention, which currently does not have a formula. So the strategies that would either lower the number of visits that Dr. Mantel was raising earlier, or that would address from a quicker standpoint the AQMD concerns, there currently exists sort of no basic formula to try and prescribe the cost benefit of resolving these challenges earlier, and what's the return on investment from prevention or from intervention strategies relative to subsequent treatment. Those are the 4 key messages that I took away from this meeting with the public health leaders at LA County on January 28th, 2016.
I will attend the next Mental Health Commission's meeting. I cannot guarantee that I can go every Thursday, but I would go to the next one and report back. Okay?
Great, thank you. So I was scheduled to go to the first Tuesday of the month County Board of Supervisors meeting, and there was supposed to be a report back on the consolidation of health, mental health, and public health for the County of Los Angeles, and that actually has been postponed to February 16th, so I'll be going to the February 16th meeting. Okay, anyone else? Okay, great. We'll move on to public comment. Mr. Herman?
So you see, you'll never miss out on something so important when you attend the County Board of Supervisors meetings, especially when Riley Thomas sits on that board there, who on a basis has not used his garage to assist homeless people to have a place of comfort and shelter from the elements of El Nino. Wouldn't that be a pleasant gesture if a county board supervisor would open up his garage that he accidentally tapped into with the funds of the county taxpayers and use that as a way of apology? That's just one example of someone actually doing something politically correct for his error in taking the public's money and abusing it. Abuse, fraud, and waste. Doesn't that sound similar to grand jury, Nuri the jury, under the FBI investigation for her so-called issues of corruption, scandal, and abuse to the public? So if we're going to have any reports, please do attend these meetings in the county board of supervisors. You may learn something there other than being called an asshole by Sheila Q. But yes, you will learn something indefinitely. How to find the resources, the benefits that would go towards homelessness, the crisis in Los Angeles, and the war on homelessness. Take a ride towards USC on the 110 and look at all the beautiful condos built on the highways of homeless encampments. Isn't that pleasant?
Mr. Spindler?
Dangerous. Very dangerous attending those mailings. Very dangerous. That's right. You have to fight for your right to talk before Sheila Kuehl and the LA County Board. So the first thing you need is a camera. You need to have a good camera when you attend those county meetings, because these scumbags will surround you by officers and they'll tell you disrupted the meeting. Secondly, bring a lawyer with you, because the chances are if you attend enough meetings like me on November the 10th, 2015, you're going to get illegally arrested, detained, and imprisoned, and tortured, and beaten, and fucking harassed, just like I did. Then when you try to file a claim against the city without a Jew lawyer, they mail you back a response, your claim has been disavowed. So that's your city. The day I go to federal court and I file my lawsuit against this fucking city, they'll get on their fucking knees and they will pay me. But I have to do that. Now, the grand jury with Nuri Martinez, who took $5 and $10 donations from people who never knew who the fuck she was 240 times over, is over there now causing the grand jury to investigate this. We had FBI agents attending our meetings last week here. They sit down and attend our meetings now. Isn't that nice to have FBI agents having to spend time attending these fucking meetings? Isn't that nice? I'm sure you all think that's great. Well, I don't. But you won't fix the corruption in the city. You won't fix the corruption in this county. So we have to go do it, everybody, the hard fucking way. And that's the way we're going to do it.
Okay, next item, item 4, is items for future discussion. This would be for agenda items for our next meeting.
Did we ever decide what the subcommittees would be? The subcommittees? Did we ever come to a conclusion?
The working groups?
Yes.
Yeah, we sent something around about that, actually. So we'll, each group will decide how they want to move forward in terms of the writing their particular section of the report.
Okay.
I'm trying to remember, what were the due dates on getting some sort of a report? Was there one sort of a 6-month one or something like that?
There's a 6-month verbal report, and
Okay,
then there's an annual written.
Okay, it's written
is
is
my understanding.
annual, verbal is, which would be, was that May? Or no, actually April. April.
I think it's May, isn't it?
November, December, January, February, March, April. April or May, yeah.
Okay. Okay, for the next meeting, any ideas?
Actually, kind of piggybacking on that issue is, we know they have this report due. We're talking about a verbal in a couple of months. We're already 1 quarter in. I just want to know, is there a time where we're going to come together as far as what the expectations are? We're talking about subcommittees, but what specifically, how are we addressing, or how are we going to tackle this report? How are we going to address this issue? Is there some type of guidelines? I mean, I would really like somebody to be able to come in and explain the process so that we can make sure that we can execute on it.
I think specifically for the working groups, if we could start working on outlines to come out of those specific working groups, I think that would help a lot. So we could see what direction people want to go in, once they begin talking about their specific area. So I think that would help. We have about 7 months, right? So I think as soon as people start talking within the specific groups, I think that we'll have a lot of information that comes out in terms of the direction that people want to go in. So I think that's what's missing right now.
But was there any direction from the institution of this commission as far as what the expectations are? Is there someone who can report back on that, just so we're all on the same page and we're all clear?
Well, I have one additional piece of information which I don't think is a perfect answer to your question, but I think it helps, at least in my mind, to think about how to structure and approach the sort of enormously mammoth task, which is that in the original construction of how the statute was written, which prescribes this commission and its duties, it articulates report back to City Council, which City Council interprets as report back to the committee with most relevant jurisdiction, which is called Health, Mental Health, and Education. So that is one lens through which to potentially look at this, i.e. that would be the first recipient. This full City Council is improbable, unlikely to schedule such hearing back. So if there was an intermediate step, which was to address that particular committee, are there some jurisdictional questions that are of interest to that committee, or that committee is most likely to be able to act on in the near term, that might help frame some of what goes into the report, or at least what gets in as the top line recommendations in the report. And that's a tighter focus for sure than what was initially prescribed as sort of looking broadly at all county meetings, all county health services. And so I think it's somewhere in the tension between those two extreme poles that we'll have to resolve what we choose to focus our limited resources and efforts on.
So is there a structured like timeline? I'm just trying to figure out, if we break out into our work groups, what is the timeline? What is the direction? Do we all come back together as a commission, figuring out, there's so many, all the reports have indicated, it's a very multifaceted issue. So as far as what will be the highlighted topic issues, how are we going to come back? Do we come back as like a strategic retreat? Is there something, what is the mechanism? What is the vehicle?
We would come back to this meeting because the meeting is open to the public, number one. Number two, I think as soon as we start in our work groups in terms of outlining and deciding what direction we want to go to, I think a lot of that will come out. I think we have to start doing the work and then see what comes out of that in the next report back next month, and then the next report back after that. But until we start doing the work, we're not going to know what direction we're going in. That's why we divide it up into the various work groups. So we could talk about these issues, what direction we're going in, and then we can come back and do report backs. And then I think in terms of a timeline, if we could start having an outline from the various work groups in the next 2 months, just sort of sketchy outline, I think that would really help. And then we can, at that point, we can talk about a document that we have in hand as opposed to everything else that's out there that we keep talking about. It really helps to have something in writing, to look at it, to see if it's the direction that we want to go in these specific areas. But I think we have a good framework. I think Commissioner Esparza has created a good framework for us to bounce off of, and we have our working groups. So I think we just need to start there.
If the city clerk could, at your convenience, send us all a copy of the original law so we know and we can interpret directly, so we have a little bit more motivation to do what we've been earmarked to do.
Well, it is the four, it's attend meetings, all meetings, which I still have an issue with because that word all leaves not a lot of wiggle room. And so I still think that that is not realistic because there are a lot of meetings going on throughout the county. So I think that should still be revisited, particularly as we focus our attention, and we can't do everything. So that's one. But then also publish an annual health services plan setting forth health information, including but not limited to the health needs of the city, which was a major part of it. And then prepare and present the report twice yearly. And if one is going to be verbal and the other one written to the city council. And then lastly, review on an annual basis a representative sample of health services contracts executed by the county. So I don't know that we have a subcommittee related to contracts, or do we?
No, we don't.
Yeah.
There were four. The second and third sounded very similar to me. Can you read them again?
Sure.
The difference between numbers 2 and 3?
Number 2 is publish an annual health services plan setting forth health information, including but not limited to the health needs of the city, specific goals for improving health in the city, and a strategic plan to achieve those goals. To me, the CHIP sounds very close to that. And the City Council shall consider and respond to the Commission's annual health services plan in a public meeting to which the Commission members and Commission staff shall be invited. That's all number 2. Number 3 was prepare and present a report twice yearly to the City Council evaluating the city's progress toward meeting its health goals as set forth in the Commission's annual service plan.
So the third one could potentially be delayed till after the second one was completed, if there was to be a separate, entirely brand new plan. Since the City Council adopted this ordinance, the City Council subsequently adopted the Plan for Healthy Los Angeles, which presents itself, as we heard from city staff 6 weeks ago, I guess, as a plan for how health and health services are to be provided in the city under the jurisdiction of city departments, which is obviously not as broad as capturing the work that the county needs to do better, which is part of our charge. But so there's some question, I guess, that we would benefit, or at least I would benefit from clarification on as to how much new material is needed to satisfy that requirement, given that there's some additional action that was not anticipated at the time that this was drafted, that the City Council's taken, that I think, at least as best as my reading it, is 170 pages of very detailed actions to take that may help us at least get part of the way there towards number 2.
Can I just bring us back to this item for future discussion? So we do need to have an agenda for the next meeting. So if you have ideas for speakers that can inform some of the working groups, I'm learning a lot here. I'm sure that a lot of other folks are learning a lot just from the presentations. So if there are specific ideas that you have for presenters, I guess you could let us know if you don't have anything now.
Can you go over the agenda setting process, just so all commissioners can know the timeline that you've been working on to put together the draft agenda, and how folks can contribute to that? If I could bother you to grab the mic, that'd be great. Thank you.
So basically, 2 weeks from today, you will be sending your items to the president and the first and second vice presidents. They will in turn submit it to the clerk. They will let us know what items will be on your next agenda. And in terms of presentations or PowerPoint presentations, those need to be done ahead of time, at least 1 week before the meeting. So again, the first step will be for you to decide what items will be on the next agenda, and those will be communicated to your president, your first VP, and your second vice president. They will in turn submit that to the clerk.
Just as a possible topic, apropos of what they were discussing from as part of the issue of how the city deals with environmental impact reports, maybe the planning department or somebody like that. I mean, what do they take into consideration? We know they talk about traffic impacts and so on, but we heard here about an environmental impact that wasn't foreseen or wasn't dealt with. I don't know whether that's appropriate, but it seemed like from the point of view of a city department that does have an impact on the health and so on of the city, it's a thought. Others can...
Great. I'm sure we could find someone to speak on that. I've noticed too that we haven't had anyone from the mental health community come and give a presentation, so I'd like to see that for the next agenda.
The housing department vis-a-vis the health department's interaction with the city health department, we heard about it from Dr. Katz. Maybe we could hear about it from the city side. Just as a thought.
The other one that Commissioner Vick had requested, which we weren't able to schedule tonight, but it may have just gone too long anyway, was to hear a little bit about what's happening with food nutrition deserts, the inequities in the availability of fresh and nourishing foods throughout the city. And I've made that contact. They weren't available tonight, which turned out to be in our favor given the hour. But they will hopefully be here for the 14th of March. I think it's our next date, 14th. Is that right?
Yes, that is your next meeting.
So that would be very appropriate for my subgroup or our subgroup of lifestyles portion of the Blum's taxonomy. So that'd be very timely to get that. But if I understood correctly, that within 2 weeks I should present, or those of us in the subgroup should present our plan or approach, including timetables and timelines about how we're going to do this and when we're going to do it.
Yes. Great.
We were talking about the fire response because of traffic accidents, or you mentioned the kid being hit by a car or whatever the case might be. It'd be interesting to see how the Department of Transportation studies and deals with getting information from either paramedics, 911, and or how they accumulate data. If there are certain intersections that are recurrent problems in regards to paramedic being called.
So City Council recently adopted a Vision Zero plan. There's been a Vision Zero coordinator hired with the objective of, by 2025, reducing pedestrian and bicycle fatalities to zero. I'm happy to reach out to the project coordinator, Nat Gale, for that. See if there's something we can do.
Be interesting because my understanding is that there's not a lot of communication from one department and the other.
The statistic is terrifying. It's something like 6% of the intersections or corridors are responsible for 60% of the deaths. You know, that it's one of the many inequities in how that terrible data is distributed geographically.
And deaths jump out, but then what about just recurrent paramedics being called out and trauma?
Hearing from the CAO's office regarding their homelessness budget, how they're addressing the issue.
Great. Anything else? Okay, move to public comment. Mr. Herman?
I found this elected official
very big. You guys have 2 items on the agenda tomorrow about homelessness. Yes. 14 specific items, but yet... Well, I think it's a start. Nothing started, Mr. Price. Tell Kokorian the budget man.
So you see, there's no plan. There's not even intent to figure out why you've created this crisis. You're pointing the fingers at those who live on the street, who are called homeless, those who don't have good health care, those that don't have jobs, those that are struggling just to find a place to rest our head and sleep without the fear of catching the flu or a small cold, and have the sniffles for the night or a day. How uncomfortable is that? But it's your responsibility as a commission to step up the game and push on your part for those resources. Get that little puppet up there, Herb Wesson, and lay him on his back and start kicking him around like a can and saying, do something, Herb. The people's outcry is getting louder. The main issue is homelessness, that you as a city have forgotten on the breaths of those who suffer and are oppressed on our sidewalk and streets. We're not the only city suffering the crisis. The dignity crisis on homelessness is throughout the state of California. So the hell with you, Hillary. The hell with all you Congress Democrats who created this problem. Democrats is another fancy word for rats. And rats are in fear of fat cats.
Thank you. Mr. Spindler?
Very good. Very good. I can hear an echo. See how much fun we can have with technology. So now, future meetings. The first meeting you should have is with a good federal criminal defense attorney. What type of legal liability do each one of you have in the event of a grand jury investigation? Are the things you talk about with your city attorney privileged? Or are they opened up to scumbags like me at public comment? Do I get to hear on these closed session items? The answer is yes, because on December the 30th, the Ninth Circuit, in an unpublished decision, gave a warning. They ruled any confidential communications between your attorneys is open to comment if it furthers a criminal act. And that's why they did that on December the 30th. But you don't read this stuff. Your city clerks, all these people getting paid to do nothing but go to the latest Yum Yum Donuts and get their coffee and donuts, because you would have known they were telling you something. They're telling you, the federal government, stop stealing our fucking money. That's what they're trying to tell you. Obama's being nice to you. Please, Herb Wesson, stop stealing our money. Stop stealing our Section 8 money. Stop stealing $1.4 billion for your bankrupt pensions. Please stop stealing. And what do? They're going to get another $1 billion, and they're going to try to pass a measure on the ballot to steal more of our money to put into this building. That's what you guys need to stop, and stop now.
Thank you. That concludes public comment. I'd like to entertain a motion to adjourn. Okay, all in favor? All opposed? Great. Thank you. We're adjourned.